All right.
There we go.
So today we got local and national overdose and drug trends. Should just be tons of fun with Haley and Troy. So we will get to that just momentarily. I think everybody knows us, Aaron and Kurt.
So we are going to be switching over to a new Echo format. This will be happening on December 6th. And if you haven't registered in this system already, please do so. Remember, if Kurt can do it, anybody can. And we've had about 177 of you register already. But if you haven't, please do so. Katie will be sharing that link towards the end of the Echo presentation.
My nurse did it in less than 1 minute and 20 seconds. So it's very quick. It only took me like 6 hours, but I was having a little trouble with my attention. So we have some upcoming Echo sessions. Actually, next week is not on there because it's me, and I'll be talking about poppy seeds and how they make the urine drug screens positive and how that looks. And there's some new variants of the poppy seeds that have changed how they look on a drug screen. So one of my favorite talks I gave about 1.5 years ago, and I kind of revamped it. Then we have COT coming from the University of Minnesota. Many of you may know COT from the Somali community is something that's used by some of my students, say, very frequently. So anything else? No. All right, next.
So Hennepin Healthcare, in partnership with the other organizations at the bottom of the screen, is going to be hosting a joint perinatal improvement summit. And this is happening November 15th through the 16th. Lots of great talks are going to be taking place. So if you have any interest in this, please register using the QR code on the screen, or just contact us and we can get you hooked up.
Using a QR code?
Right.
Okay. I guess they use those. Yeah, both Aaron and I will be down there doing some talks. Lots of great people other than us giving talks. So should be fun. Remember, there's free CME. Please make sure you fill out the stuff at the end to get that. And remember, Haley would love to talk to people. So please don't be afraid to show us what you're eating for lunch and turn on your video. That would be fabulous.
If you have any technical assistance needs, that is our contact information listed on the bottom of the screen. Don't hesitate to reach out if you need help with something.
Yeah, I get some of my best stories from these calls. I mean, we get some really fun calls. So yeah, don't be afraid to reach out. And I think that's it, isn't it?
Oh. Nope, we forgot a slide. So this is the core website that is available through Stratus Health, and it has a bunch of great resources regarding opioids and addiction medicine if you want to check it out or need some assistance.
Yeah, just go on your computer and go on the internet. That's where you find this.
You know how to do that?
Yes, on the internet. And it looks like that's it. So we have Haley already ready to roll. So Haley, if you want to maybe introduce yourself and kind of tell people what you really do at the state so that they have a good idea, and we'll let you share your slides when you're ready.
Sounds good. And I'm here with my counterpart, Troy Green, who's going to be presenting with me. And I think, Troy, you're going to share the slides, right? So while you're doing that, I can introduce myself and then I'll throw it over to Troy. But I'm Haley Hillstrom, and I'm the public health analyst for the overdose response strategy, which I'll explain a little bit more about once we get the slides going. But I'm sort of the public health side of the ORS team. And then Troy is the public safety counterpart. So Troy is going to start off with an introduction of what the HIDTA is, and then we're going to talk about the overdose response strategy and then get into some data.
Hi, everybody. Can you see the PowerPoint?
Not yet.
Not yet.
Right.
I feel your pain, Troy. I've been there.
I know. I'm sharing my screen. All right, let's go.
There it comes.
There you go. Looks good.
Awesome. Okay, so I'll introduce myself real quick. I'm Troy Green. I'm the other half of the ORS program, the Overdose Response Strategy team here in Minnesota, which Haley will be going into some detail about here momentarily. A little bit on my background is 29 years in law enforcement. Previous to this, I was at St. Paul during that time. A large portion of what I did during those 29 years was narcotics investigations, supervision, Drug Enforcement Agency Task Force for 5 years. I ended my career as a deputy chief in the Community Engagement Division. So that retired from there, and now I'm on the ORS team. So I'm happy to be here. Happy that we got invited to talk to you all today. You can see our agenda up on the screen. We're gonna try and keep this interesting and break it down and provide a little context. I know when we start to talk drug investigations and overdose response and all that, there's so many layers and moving parts and organizations and funding, and it gets really confusing. So we want to provide a little context about who we are, where we come from, what our mission is. We'll go through some trends, both in Minnesota here and then also nationally as they apply to overdoses and drug seizures. And then we'll hone in on that epidemic that we're all hearing so much about with fentanyl. Then you touch on emerging threat of xylazine. Finish it up with MIN test and OD map. So that's the agenda. Let's kick it off with kind of just touching base on what is HIDTA. You may have heard of HIDTA, maybe not, but it stands for High Intensity Drug Trafficking Area. It's a program. It's not an agency. It's funded by the ONDCP, so the Office of National Drug Control Policy. There are actually 33 different HIDTA locations in the country. And the one that Haley and I are a part of is the North Central HIDTA, which encompasses Minnesota and Wisconsin. It has been around for, well, Congress put HIDTA on the map, I guess, back in 1988. And its main purpose, mission is to address drug threats and reduce drug trafficking and drug production in the United States. So within that HIDTA program is the ORS, which Haley will talk about momentarily, but also to give HIDTA a little bit of context just so you understand the amount of people and resources and what it's responsible for is we are attached to an investigative support center which operates out of Hennepin County Sheriff's Office. So that ISC supports the North Central HIDTA. So the North Central HIDTA headquarters is in Milwaukee. They also have an ISC, Investigative Support Center. And within that Investigative Support Center, some of the things that are addressed are drug investigations, violent crimes, gangs. There's more of the what you would consider your stereotypical drug investigator or drug intel analyst that really support those investigations. So these analysts go out and work with the different officers, deputies, plainclothes officers, undercover officers, and they support them with analytics and information and communication and all that kind of stuff. So a lot goes on in the ISC, Hennepin County Sheriff's Office. That's where Haley and I actually office out of. That is not necessarily our role, although we do support their mission. Our role is more on the overdose response strategy side. So here you can see the 7 different HIDTA counties in the state of Minnesota. So in order to become a HIDTA county, you have to apply, you have to go through a screening process, you have to meet requirements. And really what it comes down to is you have to be one of the busiest of the busy as it relates to drug trafficking organizations, crimes, hubs, destination locations, just distribution sites for illicit drug trafficking in the state. So that's how these 7 ultimately get identified and get funding. And as part of that, they share analysts. So you'll get in the ISC that I just talked about, we have an analyst from Anoka County, Dakota County, from all the different locations, HIDTA county locations. So you get that collaboration, that cooperation. There's a lot that goes on in investigating drug cases in the state of Minnesota and in the country. There's a lot of overlap that can happen as far as, investigators a lot of times are looking at the same drug trafficking organizations, which can be a good thing, right? Many hands like work, but can also be very problematic because you can end up with blue on blue situations, we call them, where, you're both working the same case and you're not necessarily knowing you're working the same case. So you can end up on the same search warrants, or you can be working the same targets and unknowingly. So what happens with the ISC is the collaboration and the communication. You avoid those situations, you deconflict, and you actually become a lot more efficient in investigating these trafficking organizations. I'm going to kick it over to Haley because now she's going to move from ISC to ORS.
Thanks, Troy. Yeah, so I'm just going to give kind of an overview of what the overdose response strategy is and kind of Troy in my role. So the overdose response strategy, or the ORS, and you can go back one there. So it's a national program. It's funded by the Office of National Drug Control Policy and the Centers for Disease Control and Prevention. And it's a national program. So every state plus Puerto Rico and the U.S. Virgin Islands, they all have an ORS team. And each team consists of a public health analyst and a drug intelligence officer. So like we said before, Troy is the drug intelligence officer for the state of Minnesota, and he's embedded within the North Central HIDTA, which is embedded in the Hennepin County Sheriff's Office. And then I am the public health analyst for the state of Minnesota, and I'm also embedded at the North Central HIDTA, but I'm also embedded at the Minnesota Department of Health in the Overdose Prevention Unit. So together, Troy and I work across public health and public safety sectors to work on overdose prevention efforts. And if you want to go to the next slide, Troy. So the mission of the ORS is to help communities reduce fatal and non-fatal drug overdoses by connecting public health and public safety agencies, sharing information, and supporting evidence-based intervention. So our North Star is really preventing overdose deaths. And then within that, we have quite a bit of flexibility on what we work on, just depending on what the needs are of our states. Next slide, Troy. So this collaboration between public health and public safety really allows us to work across public health and public safety sectors. It allows us to share data, insights, and trends that we're seeing related to drug overdoses in our communities, and allows us to inform and help local communities develop solutions to reduce overdose deaths. And next slide, Troy. So they're kind of, like I said, we have quite a bit of flexibility with what we work on but these are the four buckets of strategies that guide all of the ORS work. So the first bucket is sharing data systems to inform rapid and effective community overdose prevention efforts. The second bucket is supporting immediate evidence response efforts that can directly reduce overdose deaths. The third bucket is to design and use promising strategies that are at the intersection of public health and public safety. And then the last bucket is disseminating information to support the implementation of evidence-informed prevention strategies that can reduce substance use and overdose. So at the end, we'll give 2 examples of projects that we work on that we think might be relevant to your guys' work, but that fall within these buckets. And next slide, Troy. Thank you. So now we're going to move into talking about some national and local trends. So I'm going to talk a little bit about overdose statistics, and then Troy is going to kind of talk a little bit from the law enforcement perspective about some seizure statistics and other kind of seizure facts. So next slide, Troy. And before I get into the data too much, just want to acknowledge that the data presented here represent real lives lost. And we know that the stories are really complicated and that the trends don't show those complicated narratives, but we hope that by looking at this data, it'll really be able to inform our prevention efforts and help us to strategically implement initiatives that'll prevent future overdoses. And I'm not going to get super in the weeds on some of the mortality statistics, because I know you all have other experts from MDH that come in and present on that. But I just kind of want to set the stage before Troy goes into his seizure statistics. So This chart comes from CDC data that shows the 3 waves of overdose deaths. So starting with the first wave, kind of a rise in prescription overdoses starting in around 1999, followed by a wave, second wave in heroin overdose deaths, which began around 2010. And then followed by a third wave, which is kind of where we're at right now with the rise in synthetic and fentanyl-involved overdoses. Next slide, Troy. So this graph here shows looking kind of drilling down further to Minnesota. So you can really see the dramatic increase from 2016 to 2022 in overdose fatalities. So preliminary data for 2022 is indicating 1,392 overdose deaths in Minnesota, which is the highest number that we've ever recorded. And next slide. This slide shows substances involved in overdoses in Minnesota. So you can really see there the dramatic rise in fentanyl and how fentanyl is really driving the increase in overdoses that we're seeing in Minnesota, which is similar across the country. Minnesota isn't unique in that. And according to Suter's data, about 75% of overdose deaths in Minnesota had fentanyl on board. Next slide. All right, now I'm going to kick it back over to Troy. Troy is going to talk about some seizure statistics.
So you can see the slide in front of you there. So I think historically we've done a lot of, we track a lot of seizures based on weight or mass. And I think now we're starting to get a little wiser about it, especially with the fentanyl epidemic, but in tracking a little more on the side of dosage units. So to explain the point here, so 2 milligrams is potentially depending on the size of the adult, potentially a lethal dose of fentanyl for a person. You can see here on the left, that was actually a recovery in Minnesota of thousands of fentanyl, illicit fentanyl pills. And over there on the right, you can see a lab that was just recently investigated, and seizures were made from down in Tijuana, Mexico. You can see a pill press there, and in the background where they're processing and bagging up the different pills. But I bring that up because when we look at weight, you can see here on the slide in front of you that methamphetamine in the blue, comprises of a very large portion of the weight of seizures that are made. And in the gray here, 56% cocaine, and this on a national scale. So, but if we go to dosage units, now you can flip it. Now you have methamphetamine down at only 7%, cocaine at 6%, but you can see fentanyl at 82%. So if you go locally here, North Central HIDTA, Minnesota, Wisconsin, you can see that looking at the chart, you would assume that, well, we have, our biggest concern problem is methamphetamine and cocaine. But when we go dosage units, we start to see that, well, actually fentanyl is a much larger percentage of what we are seizing out there. Here are some just breaking down the specific different types of drugs. Here's cocaine seizures by year. Try to follow the blue line and not the red bars, because there are some anomalies that happen or some large seizures that happen. But the blue line really kind of tells the story. For cocaine is kind of trending downward a little bit. Same with methamphetamine as we get to 22 and continuing in 23, that blue line trends down. Heroin seizures since, 2018, 19 have been trending down. And if this continued on to 2023, you would see that line continuing to trend down. And fentanyl seizures, there you can see where we're at, where the fentanyl and that line just continues to trend upward. Here you have North Central HIDTA and the United States in a comparison, and you can see where us here in North Central in the red, and overall United States in the blue. From left to right, you can see how we are kind of in line with what's going on across the country. I mean, we're not all that different from all the other states and the epidemic with fentanyl. So that was HIDTA statistics. If we look at a more comprehensive look for Minnesota, we would look at Minnesota Violent Crime Enforcement Teams, because they have teams in that cover every county in the state. So if we look at seizure data, now we're going back to weight, but it still tells the same story for methamphetamine trending down. If we look at heroin seizures, again, trending down. Cocaine, same type of stuff, a little more volatile, but overall it is trending down. But then their fentanyl seizure pills are way up and continue to go up. And you can see just in 2023, and the year's not even done, and this is only comprises half of the year. This isn't even the full year of 2023, and this is the full year of 2022. You can see the direction that we're going. So a lot of our fentanyl laced pills primarily are manufactured in Mexico by two cartels. The Sinaloa and the Jalisco cartels are the two most prominent. The precursors for fentanyl are mainly coming from China and India. They make their way over to Canada and Mexico, where there are labs, mostly in Mexico, where these labs or super labs process it into synthetic fentanyl, and then it either crosses the border in powder form, where then it is pressed into pills, or it is pressed into pills in Mexico and then crosses the border. That's Southwest location, that's Southern California, Arizona area. The location up in Canada, a lot of what we're finding out more recently is US mail and FedEx and what have you. A lot is coming through the mail, and that is primarily coming from locations in Canada. So you can see down in the lower left here, all these little red dots represent traffic stops in 2022. But you can see, following the intel from Mexico, how the fentanyl comes into the country. Southern California, Arizona, makes its way into the country, and then it flows west to east. And there we are. There's our HIDTA, North Central HIDTA. You can see our HIDTA locations, our HIDTA counties in Wisconsin and Minnesota. You can see how the transportation system, i.e. the major thoroughfares, highway system, are very much in line with our HIDTA locations or our high intensity drug trafficking areas. So Domestic Highway Enforcement Initiative, which is also a program underneath HIDTA. You can see the different programs, the different funding that goes into interdiction of drugs coming into the country. You can see in the legend there, it shows you all the different corridors that are focused on doing interdictions. I was just on a call 2 days ago with the director of the ONDCP, and he said in 2022, street value $22 billion dollars street value of seizures on these highways. It's kind of staggering. So one of the trends that's happening now is we used to see mostly pills coming across from Mexico, but now we are seeing more powder, more and more. A couple months ago, it was kind of equal as far as powder and pills coming across the border, but these pill presses now are being set up inside the U.S. And then when the powder comes over here, it's pressed into pills, and then it's trafficked out that way. So this really provided a lot of context for me. Maybe it will for you. And why, fentanyl is so deadly or so dangerous. We know that it's such a small amount of fentanyl, the equivalent of maybe 3-4 granules of salt. In one pill would be a lethal dose for an average size human being, adult human being. So if we look at it from a chocolate chip cookie concept, imagine that the chocolate chips are actually fentanyl blended, mixed in, and then pressed, blended into the powder and then pressed into pills. Well, a lot of opioid people that are using opioid or synthetic opioids, they may only use a half a pill or a quarter a pill. And on that occasion, they might only get, in our analogy, maybe 2 or 3 chocolate chips. Well, the next time they get a pill, or using the analogy of a cookie, maybe that half of the cookie doesn't have 2 or 3 chocolate chips. Now it has 7, 8, 9, 10 chocolate chips in it. So you can see where it's the quality control, and it's so each pill is different, and the whole one pill can kill, and just you don't know what you're putting in your body, how lethal it can be from one pill to the next. Haley, how about some xylazine conversation?
Thanks, Troy. Yeah, I'm just going to touch on xylazine here a little bit. I'm pretty sure you guys have had people whole echo presentations designated to xylazine. So I'm not going to spend a lot of time on it, but did want to touch on it since this is an emerging threat that we're keeping an eye on. But xylazine also kind of goes by the street name of Tranq or Tranq dope. It's a long-acting sedative, and it's an animal tranquilizer, so it's not a controlled substance, although I believe some states have moved to schedule it, but it's not approved for use in humans. Some common side effects of xylazine include respiratory depression, slow heart rate, low blood pressure, blurred vision, disorientation, drowsiness, coma, and severe wounds that can lead to necrotic tissue. And kind of one of the unique things being that often the wounds show up in areas of the body other than where is being injected, or if somebody's smoking or snorting xylazine, still seeing those wounds, which is something that's pretty unique about xylazine. Next slide, Troy. So it's used illicitly due to its sedative effects, and it's fairly accessible. We have been hearing that most people, or reports that most people tend to prefer to avoid xylazine, but have been hearing reports that some people do seek it out because it gives fentanyl legs. It sort of extends that high of fentanyl, so it has potentially some desirable effects in that way. But we've also heard reports of theft from veterinary clinics, as well as illegal sales online. It comes in like a white to off-white powder, commonly extracted or salted out of the pharmaceutical injectable. And current reporting indicates that xylazine is being added to drugs sort of towards the end of the supply chain. So not being added before it crosses the border, seems to be added closer to the retail level. But of course, that could change very quickly. But I think current reporting is still the consensus that it's being added later in the supply chain. Next slide, Troy. This is a map of counties that have had at least one xylazine involved death. So you can see it's pretty spread out across the state. This data was last updated in the spring, so it's possible that additional counties have been added, but just kind of wanted to show the geographic distribution there. And next slide. Kind of the same thing, but looking at it a different way. So this is showing xylazine overdose deaths by region. So you can kind of see the magnitude of it in different regions. So clearly the metro is seeing the bulk of xylazine involved deaths, but it is definitely touching other regions as well. Okay, so now we're going to move into, just to end off here, Troy and I are going to talk about two relevant projects of ours. So I'm going to talk about MinTest, and then Troy is going to talk about OUD map. So if you want to go to the next slide, Troy. So MinTest is the Minnesota Timely Emerging Substance Testing Program. This is a program that Troy and I coordinate. It is a partnership between the Minnesota Department of Health's Public Health Lab and local law enforcement agencies. So the goal of MinTest is to identify novel substances and local emerging drug threats in order to provide timely information to public safety and public health agencies. This is a kind of a diagram of our workflow. So we test both physical substances and clinical samples. So how it typically works is if one of our partner law enforcement agencies recovers a physical substance, so either like at the scene of an overdose or maybe just in the course of their regular activities, and the substance is not going to be part of any criminal charges, and it has some sort of public health relevance. So maybe it has a unique appearance, or maybe the person who consumed it is acting different than you would expect given what the substance looks to be. The public health lab will test it. So the law enforcement agency will fill out our sample submission form. They'll drop it off at the public health lab. The public health lab will test it. They report those results back to me, and then I do kind of like an internal alert write-up and then send that out to partners. And then similarly, for clinical samples, when one of our law enforcement partners, if they respond to an overdose where the person is transported to the emergency department, they'll fill out that sample submission form, and then the public health lab will call over to the hospital to request those clinical samples be sent to the MDH lab for testing. And next slide. So the goal of MinTest is really to fill a gap. So typically only substances that are seized by law enforcement that are part of a criminal investigation will undergo any kind of drug chemistry testing. And even when that does happen, there's often a really, really long lag time. And so in the absence of like timely drug chemistry testing, we often misclassify substances. So MinTest allows for a more timely analysis of these samples, and it helps to provide a more complete view of the drug environment by providing insight and identification of emerging trends. And then the hope is that that information will inform our participating agencies, their community outreach efforts, and also improve first responder safety. And next. So these are just examples of two alerts, kind of like what the results would look like. So I usually include like a description of the situation of the overdose, description of the sample along with photos, and then the lab results, and then a significant section trying to sort of situate the results in the context of national and local drug trends. And next slide, Trey. So since the program began in August of 2020, we've been able to partner with 15 public health and public safety agencies. We've been able to test more than 75 different substances from more than 50 different overdose and seizure events. And we've been able to identify several emerging drug threats, such as parafluorofentanyl, clonazepam, bromazolam, morphine, xylazine, and metonidazine. And next slide. Okay, now I'm going to throw it back over to Troy. Troy's going to talk about one of our other projects, which is OUD map.
Thanks, Haley. So we're on the home stretch. I know we're approaching our time here. So one more project that we work on a daily basis is called OUD map. It is basically a free web-based tool that we can enter. Counties, law enforcement, first responders can enter information on a overdose real time. So imagine, EMS or, investigators the same day, as close to the event as possible, entering details on an overdose and then dumping it into a program that everybody has access to. Okay. It's there's not data, there's not, how do I say it? There's public data, and then there is private data, right? So it only really requires a location, a date, a time, whether naloxone was used or not, and whether it was a fatal or non-fatal overdose. So it uses GPS coordinates, longitude, latitude. It does not store addresses. It doesn't store patients' names or date of birth, nothing private. It really only focuses on some information on the overdose so that it can be tracked using this platform. So right now, all 50 states on some level are using OD map. You can see Minnesota there is pretty lit up, which is good. We got a little bit of work to do yet, but most of the counties are accounted for. There's over 4,500 different agencies across the country that are entering this information into OD map. So you can imagine how powerful of a tool that is when that much data is going in and it's real time. Now, understanding that with real time, you're also sacrificing some of the accuracy of the data. But what you're trying to avoid is the situation where you're waiting 3, 4, 5, 6 months to find out if something was an overdose or not. And by that time, it's pretty hard to go out and have efforts at trying to prevent overdoses that far down the road. So the OD map it identifies spikes. So when there is a location, there's thresholds that are set. So like here in Hennepin County, the threshold may be set at a certain number of, like, maybe it's 10 overdoses in a certain time frame. If it reaches those 10 overdoses in a certain time frame, it triggers a spike alert, and then that spike alert is communicated any different number of formats. But then that's where public health and first responders and harm reduction efforts and can go and communicate what's happening. Maybe it's a matter of distributing more naloxone to an area. Maybe it's just communicating the threat in that area, notifying first responders that if they're going to a slumper call or a person down call, that it may be a higher priority because of the emerging or because of the spike alert that's happening. So it really is a powerful tool. As you know, just the information, it really helps identify what the situation is at any given moment, whether it's in the country or in a state or in a community. And it really helps us focus where our efforts should be, where we should be focusing more resources, more education, and what have you. Super powerful tool. So I think 291 is the number I last saw in Minnesota, as far as agencies here locally that are participating. So you can watch trends, you can see trends that are happening with different drugs. It really is an amazing platform. So that's what I have on OD map. Haley, anything I miss on OD map? I'm not as fluent on talking about it as you are.
No, that was great. The only thing I would add is that it's not a publicly available platform. It's only available for first responders and for government agencies.
All right. If there's questions, if people want to unmute or they want to chat them in, that'd be fine. I know we have a couple, and I guess I'll start since I'm already talking. One of the things you talked about was, some of the different things with veterinary offices, like there's been people are breaking into them and such. We actually had the veterinary medicine people on from the University of Minnesota. And I think all of us were very stunned at how there is absolutely no oversight of any of the controlled substances on the human side that are controlled are not on the veterinary side. Is that something that you guys see? The veterinary clinics are a big, a lot of diversion from there, or get tracked back to that?
So, yes. So yeah, actually, yeah, we do. And then some of those things, until they become scheduled, that it can be problematic. And just education, right? Education on when that happens, what to do, how to report it, how to investigate it, why it's important to investigate it, and those type of things. So, Haley, anything more to add on that?
Yeah, I'm not much to add. I guess my understanding is that a lot of it is coming from on just ordering it online, because it is pretty easy to just order it online. But like Troy said, I think we definitely have heard reports of it being like theft from veterinary clinics. But in terms of like how widespread, or like the breakdown of where it's coming from, I'm not exactly sure. But I do believe that like online sales is still the bulk of it, even though like the veterinary sales or theft from veterinary clinics definitely is happening, or there are reports of that. But yeah, I think so, that is a really interesting point.
And then some I can follow up with the DEA and their diversion investigator over there and see how widespread it is here locally, and if there's a better answer we can provide you, I'll make sure you get that.
All right.
Christine Bell asked some really good questions in the chat. Wondering if age is also tracked in the OD app. And Haley did respond to that age is optional, and it can be entered if the department chooses. And then she also asked, is it optional to add data or required when there is an OD?
It is optional. So agencies opt in to use it. There is no requirement. Some states have legislation that requires first responders to enter data into a OD map or a platform similar to OD map. But in Minnesota, we unfortunately don't have anything like that. So it's just voluntary. So one of kind of the things that Troy and I work on is going kind of agency to agency, trying to help them get set up with OD map so that we are able to share that data in real time. And then just kind of to expand on Christine's first question. So age and gender are both optional fields, but the fields that are mandatory are if it was a fatal or non-fatal overdose, how much naloxone was administered, and is there one I'm missing, Troy? Suspected substance is another optional one. So there's a few optional fields that give a little bit more context, and then there are a few that are required.
Okay. I think there's we all understand that on the reservations that the risk of overdose and death is like pretty high. Are the tribal governments linked at all into your programs?
Yeah, it's available for tribal governments. Some are using it, some are not using it. So it just kind of depends, but it's the tribal governments. If we have 2 tribal governments where their public safety agencies are using it pretty consistently. So it just sort of depends, but yeah, it's definitely available for tribal governments.
April put a good question in the chat. She said, are you finding fentanyl in marijuana? I have heard conflicting reports on this.
Everybody wants to know.
Go ahead, Haley.
Yeah, no, that's a good question. I can start, Troy, and then I can throw it over to you if you have anything to add. But no, I don't think we have seen any lab confirmed cases in Minnesota. I think there are a lot of reports floating around about like initial testing where the marijuana will test positive for fentanyl. But then when those get back to a lab for actual confirmatory testing, fentanyl is not found. So I think that's kind of where the conflicting reports come in. But to my knowledge, there's only been like one lab confirmed case of marijuana that had fentanyl in it after it underwent lab testing, and that was thought to be an accidental contamination. I think part of the logic there too is that the combustion point for marijuana is so high, like the fentanyl would burn off before it could have an effect. So there's not really much incentive to add the fentanyl to the marijuana.
You didn't really talk much about the mix. And I think in our clinic, we're seeing a lot of people who number one, probably are using methamphetamine that has fentanyl in it, and we're totally unaware. I've seen that once with cocaine, which, to be honest with you, I'm seeing more cocaine now than I have in a long time. Any comments on the mixtures that you're seeing?
A lot. So, and it's hard, and there's still a lot of unknown still, but one of the thoughts is that a lot of this stuff it's more contamination, and it's not intentional. So imagine these labs, imagine, someone in a house or at a lab blending, methamphetamine in powder, breaking it from a crystal or from a pressed block of cocaine or whatever, and they put it into a blender. And then they don't have great practices. They don't clean the equipment, and then they put in a batch of pills and they blend up the pills, and you get this cross-contamination stuff that's happening. So there's a lot of thought that is happening. Not to say that there is not intentional lacing of drugs going on, but maybe not to the extent that we might think it's happening. It's just there is a lot of unknown there. And when you start talking about just a minuscule amount of fentanyl it required for a potential overdose, you can see why that's a problem, So the best answer there is not sure, but it's definitely happening. It's just whether it's intentional or not, that's still unknown.
Yeah, and just adding on to that, in talking with the BCA lab, it doesn't sound like they're seeing it as much in their samples as I would have expected in terms of like when they're testing methamphetamine or testing cocaine and the percentage that also test positive for fentanyl. So it is, like Troy said, I think a lot of that is unknown and up for interpretation, but just wanted to mention that in the data that the BCA has been testing, the percentage that tested positive for fentanyl also was quite a bit smaller in terms of a percentage than I would have expected, given a lot of the reports that we're hearing.
I think this is, some not overlap, but collaboration and additive information is especially helpful, that the focus of these different programs and ways of analyzing things is complementary. I think in a lot of ways, because there's a lot missing from one of the databases that we try and collect, and hearing some of the information today. So I think the other thing is that, the difference between testing a drug sample and a clinical sample is different. So that we are seeing folks who have confirmatory testing for both, but that's entirely different than saying that it's both were in what they used that day. Just because they're both in somebody's system doesn't mean they were mixed together. And then I'm wondering if you could elaborate a little bit more on the process of law enforcement, and then probably EMS is transporting somebody to an emergency department in Minnesota, and then the Department of Health is contacting the emergency department to collect clinical samples. Could you? I'm struggling a little bit with the process. And full disclosure, I work with Mendoza.
Yes. And so it's the MinTest program is sort of it's a little bit of a complement to Mendoza in terms of the physical samples, but yes, when we're collecting the clinical samples, and I should say it is not on near as large of a scale as Mendoza, so it is not nearly the level of volume as the Mendoza program. But how it works is if the police department, if they're responding to an overdose, they know that the person was transported to such and such hospital, they will contact the public health lab, and then the public health lab will call over to that hospital, see if any samples, clinical samples on the individual have been collected. And if they are, usually the hospital is willing to send them to the public health lab for testing. Oftentimes, I don't know a percentage off the top of my head, but it's very common that when the public health lab calls over to the hospital, there haven't been any clinical samples collected. So it is a little bit hit or miss since it's not like a formalized process like Mendoza is for sending samples to the lab. It's very dependent on if the lab can make contact with them in time and if they did collect any clinical samples. Does that answer your question?
It does. I'll follow up maybe with an email, and I appreciate it. I'll just share, Mendoza is also hit or miss, in terms of getting folks in. I just, because this is not a public health mandate, it's a public health process and surveillance, but I'm just wondering about the consent process there and informed, you know what I mean? And I don't want to say less so. I get public health, again, reporting is one thing, but if it's not a system that's set up and it's sort of a cold call from the Department of Health to say that it was our staff who had questions about sharing this information and samples, if that makes sense. And it's different from public health reporting of other things, and that it's illegal activity that may be involved here. You know what I mean? So I'll follow up a little bit more in an email, but it's helpful. But thanks. I appreciate it.
Yeah, definitely follow up. Be happy to talk more.
I have a question. In the past, we've heard stories about like meat tenderizer or baby formula being used as bulking agents with fentanyl or heroin. With the pressed pills, what are the most common bulking agents that you're seeing, and do they have any risk for harm?
Great question. I don't know that I can give you a great answer on that. There is dozens and dozens of different bulking agents that go in for cut, in these drugs. I don't know. I can't give you an exact on that, but that's another thing I can definitely follow up with some of the task force to see what they're seeing or hearing, and then also the state lab, to see what information they have.
I think
Haley, do you have anything?
Just because, if it presents in like skin ulcers or, GI issues or whatever.
Yeah, I think that's a good point. Through the MinTest program, the only results that are reported to me are like the active ingredients, but that is something that the lab has thought about doing through MinTest, is like tracking in pressed pills how the fillers may have changed over time, because I think it does seem like it's things trend up and trend down. So yeah, I don't have an answer either, but I think it's a really important question and something that we should be looking at.
All right.
So, I wonder, could I one last one?
Oh yes, absolutely.
And thank you really for this presentation. Again, it's not just collaborative, but really informative, and the resources that you have. And so I know I'm asking a question that we don't have an answer to yet, but it sounds like if the right people to ask are you guys on this call. So any thoughts or discussion or what you've heard about why the number of fatalities that involve fentanyl, which plus xylazine as opposed to just fentanyl, are not showing up as, I'm going to say, more in combination? That's number one. So that xylazine not to sort of thought to worsen the number of fatalities, and actually fewer cardiac arrests. So I'm just shooting information from different resources, although some of this I think is from CDC, and that it's pretty confusing. We think, I'm not saying that xylazine's not bad with the decreased level of consciousness in combination with opioids, but there's not really a great mechanism for respiratory depression. But I don't know why we're seeing what we're seeing. And is that what you guys are finding as well in terms of reporting of overdose fatalities? Is that kind of the message right now, is that it's unclear and not been shown increase the fatality rate?
Just to make sure I understand your question, why hasn't xylazine seemed to increase the fatality rate?
Yeah, it doesn't. Correct. Right.
Yeah, I think that's a really good question. And I know there have been a couple of papers that have come out recently, which others on the call may be much more familiar with than I am and be able to speak to them a lot better than I can, but about looking at like xylazine as potentially acting on opioid receptors and potentially being somewhat responsive to naloxone. I will admit that I haven't dug into the studies too deeply, but I do know that there has been some more recent, like in the last couple of weeks, research out there that maybe speaks to that a little bit. But I don't know. I don't really have a good answer to that question. I think it's a really good question.
No, and I think, again, my messy question with all the prefaces, I don't think we have one. So thanks. I appreciate it. And the part about acting on the opioid receptors, like you say, more to come. I think if we're going to lump it in the same class as the other alpha 2s, I think there's a bit more concern as well because it doesn't have one of the other effects that the alpha 2s have. And so the bottom line is more to be seen. We don't at this point suggest that higher doses of naloxone be tried in the out-of-hospital setting. In the anecdotal cases, high doses of naloxone, I couldn't even tell you, like, how often is that even tried? But clinically right now, as you point out, a lot to still be found, still needed to be looked at. And at this point, I think the message still is that naloxone works for opioids. It's not necessarily that we need enormously high doses, especially first dose. That's some pretty impressive data. And then the other part is down the line, if we think that this works in a similar way to the other alpha 2, those doses are really high, and that's not necessarily panned out in the clinical setting either. But I agree, those papers are out there, and it's great that they're being done.
Yeah, thanks for those comments. I think that's a really good point. And what we're hearing too, just in general about maybe too many doses of naloxone being administered. So that's, I guess, kind of tangentially one of the things that Troy and I have been working on also is with law enforcement, kind of trying to maybe retrain on that a little bit and trying to emphasize like rescue breaths and waiting time between doses. So thank you for those comments.
And thanks for doing that education too, really.
Yeah, and there was just a comment by Christine Bell, but again, about the respiratory drive not decreasing as much with xylazine, which I think is the sedation without that, which again, I think more to come. So, well, we're about out of time. My gosh, we're so happy you guys could come. We try and get you guys back here every so often. So, expect us to reach out again in 10 or 12 months and see what's happened in that interim. And again, thank you. Thank you a ton for coming on and sharing what you know.
Yeah, thank you for having us.
Thanks, everybody.
All right, everybody, remember next week we're going to talk about poppy seeds and what they do to your urine, all kinds of fun stuff. So we'll see you then. Thanks again.
Take care, everybody.